It's time to step on the gas. Today's topic is cardiopulmonary bypass, essentials any anesthesiology trainee should know before they step into an operating room for cases involving the heart-lung machine. It's far too large a topic to be covered in a relatively short introductory lecture. It's safe to say that modern open heart surgery is impossible without the use of cardiopulmonary bypass. Without a heart-lung machine, we couldn't do many of the complicated repairs which are undertaken as a matter of routine in the operating rooms of many centers around the world. Arguably, some surgical procedures shouldn't even be attempted unless the option to put the patient on cardiopulmonary bypass is available. I'll introduce you to the technique of cardiopulmonary bypass and emphasize how important it is that you, consistent with your local culture and practice of course, take shared ownership of the management of cardiopulmonary bypass as it impacts the patient's physiology. I would argue that absolutely is your responsibility as the anesthesiologist. I remind you that your perfusion team is a valuable resource who know their craft. They should be engaged as fellow professionals in common cause, but they are not physicians. It is up to the physicians involved in the care of the patient to determine and set the specific physiologic goals for any given case. Work with the perfusionist to meet those goals within the boundaries of what is technically possible. Having seen it done practically daily now for over a decade, I will remind you that placing the patient on cardiopulmonary bypass is potentially lethal to the patient if done incorrectly. Respect the power of what you're doing and stay engaged with the process while on cardiopulmonary bypass. Now is when someone will usually put up a picture like this. This diagram is taken from Glenn Gravely's excellent text, Cardiopulmonary Bypass and Mechanical Support. This tangle of lines, arrows, and captions is certainly complete, but when I introduce this topic, I like to take a more simplistic approach. This figure, which is also taken from Dr. Gravely's text, presents cardiopulmonary bypass in a far simpler schematic. We need 6 things. We need a way to get blood out of the patient and to collect it all into a common reservoir. This will include blood from venous cannulations, handheld cardiotomy suctions, and any vents that the surgeons place into the surgical field. We need a way to physically pressurize and pump blood through the remainder of the apparatus and back into the patient. Roller or centrifugal pumps are the 2 commonly used apparatus for doing this. We need a way to heat and cool the blood. This is the heat exchanger. We need a place where gas exchange can occur, where oxygen can get into and carbon dioxide can be removed from the blood. This happens in the oxygenator. We need a way to stop the heart with a potassium-containing solution called cardioplegia. And we finally need a path to get blood back into the patient via an arterial, often aortic, cannulation site. Once all these are in place, we can divert deoxygenated blood from the right side of the heart, and we can pump oxygenated blood back into the systemic circulation. The heart and lungs are thereby bypassed. Heparin was originally isolated from liver cells by J. McLean in 1916 while he was a second-year medical student at Johns Hopkins. It binds antithrombin 3 and is listed in the World Health Organization's list of essential medications. In 2018, the Society of Thoracic Surgeons, the Society of Cardiovascular Anesthesiologists, and the American Society of Extracorporeal Technology published guidelines for anticoagulation during cardiopulmonary bypass. While no lower limit of ACT was scientifically established as safe for placing a patient on cardiopulmonary bypass, the guidelines do list as a Class 2B recommendation that an ACT of 480 be achieved before placing a patient on cardiopulmonary bypass. For patients in whom heparin is contraindicated, and that's a topic worthy of its own talk, direct thrombin inhibitors such as bivalirudin may be used as an alternative. But these are inferior to heparin due to the relative increased intensity of the regimen required to monitor the degree of anticoagulation, as well as the inability at this time to readily and specifically reverse them. During cardiopulmonary bypass, we are proposing to take the patient's entire blood volume, drain it through plastic hoses into a bucket next to the bed, and then pump it through more plastic hoses to an oxygenator and back into the patient. Needless to say, keeping the blood from clotting is vital to avoiding a therapeutic misadventure. Heparin remains the gold standard for anticoagulation during cardiopulmonary bypass and really should be utilized whenever it is reasonable to do so. Here we can see a typical cannulation strategy for placing a patient on cardiopulmonary bypass. A multi-stage right atrial cannula is used to drain blood to the pump reservoir. This reservoir is almost always kept at a level below that of the right side of the heart. Resultantly, drainage through an appropriately sized venous cannula can be totally passive, driven only by hydrostatic pressure and siphon action. In cases where venous drainage is unsatisfactory, a partial vacuum may be applied to the venous cannula in an attempt to enhance the drainage. In the reservoir, it will be combined with the blood actively pumped from the left ventricular and aortic root vents. These are used to keep the left ventricle empty and reduce myocardial wall tension. Myocardial wall tension is one driver of myocardial oxygen demand. Not pictured here are the handheld cardiotomy suction cannulae, which the surgeons can use to remove blood from the surgical field. These too drain into the reservoir. The blood will be pumped from the reservoir through the oxygenator and heat exchanger, and then back into the patient's systemic circulation via an arterial cannula. Here it is shown as aortic. However, almost any large artery could be used, such as the femoral artery or the axillary artery. After aortic cross-clamping, the heart will be stopped or pleged using a high-potassium cardioplegia solution infused through an aortic root cannula and a retrograde cardioplegia cannula placed into the coronary sinus. The cardioplegia may be entirely crystalloid, but is more commonly a mixture of cardioplegia solution and blood. Once upon a time, surgeons would simply clamp the ascending aorta and carry on with the surgery. A short time after clamping, the resultant myocardial hypoxemia would result in cardiac arrest during the systolic phase, as ATP is required to release actin from myosin in order for the muscle to relax. Time to reperfusion became the essential component to myocardial recovery. Surgeons from this era, some of whom still operate, emphasized speed as the primary means of protecting the heart. Yet, despite myocardial ischemia times that would sometimes only be in the tens of minutes, some proportion of patients' hearts never recovered after unclamping of the aorta and reperfusion of the heart. I would recommend you look up something called stone heart syndrome for one example of how it could go wrong. Cardioplegia came into wide use in the late 1970s. The high potassium solution decreases the resting membrane potential of the myocyte and prevents repolarization. Thus, in contrast to hypoxemic arrest, cardioplegic arrest of the heart will occur in diastole. Over the decades, multiple adjuncts in the cardioplegia solution have been tried in order to confer a higher degree of protection, as well as crystalloid and blood-based cardioplegia protocols. However, nothing other than EKG, electrical silence due to cardioplegic arrest, and myocardial hypothermia have been definitively shown to protect the heart. And still, despite cardioplegia, it remains the clamp time, cardiac ischemia time, which will be the most impactful factor on the post-pump cardiac recovery. In general, shorter clamp time, which is shorter myocardial ischemia time, is better. So the surgeons have successfully made sternotomy, placed cannulae in the right atrium and in the aorta, and the patient is now on cardiopulmonary bypass. What sorts of things should we worry about? This list is not meant to be comprehensive and only serves to illustrate that while things might become less hectic in the operating room once safely on cardiopulmonary bypass, there are still plenty of ways to mess it up. I would suggest that ensuring adequate end organ perfusion ought to be your single most important consideration. Anything else is ultimately in service of that overarching goal. The goal of cardiopulmonary bypass is to keep oxygenated blood going round and round with a sufficient head of pressure to perfuse the capillary beds. Do that well, and your patient is likely to come through the pump run with fewer complications. I am going to show you the important mathematical relationships to keep in mind. My apologies, but there's no getting around the math. Equation 1 tells us that in the spontaneously circulating patient, oxygen delivery is the product of cardiac output and arterial oxygen content. Similarly, equation 2 tells us that under the continuous flow conditions of cardiopulmonary bypass, oxygen delivery is the product of pump flow, here indicated by Q, and the arterial oxygen content, which is fully expanded here. We ignore the contribution of the oxygen, which is directly dissolved into the blood, and instead focus entirely on the oxygen, which is bound to hemoglobin. In the spontaneously circulating patient, blood pressure is the product of cardiac output and systemic vascular resistance, sometimes referred to as vascular tone. This relationship is given by equation 3. Cardiac output, notice, is a common factor in both blood pressure and oxygen delivery in the spontaneously circulating patient. We worry about blood pressure in the spontaneously circulating patient because we take it as a surrogate indicator of cardiac output and therefore oxygen delivery. Equation 4 shows the determinants of blood pressure during continuous flow. Blood pressure will be the product of pump flow, represented by Q again, and the resistance to that flow, which is given by the Hagen-Poiseuille equation and expanded here. The pi r term in the denominator refers to the cross-sectional area across which the flow occurs and essentially represents a combination of the cross-sectional area of all the pump tubing through which the blood is being pumped, that is fixed, and the vascular tone of the patient, which you can manipulate with vasoconstrictors and vasodilators. L is the length through which the flow occurs and will be fixed for any given patient-pump combination. Mu is the viscosity of the blood and is proportional to the hematocrit of the blood and inversely proportional to the temperature. I want to emphasize that while on cardiopulmonary bypass, unlike in the spontaneously circulating patient, all the relevant variables here can be manipulated. Pump flow, vascular tone, hemoglobin and hematocrit, hemoglobin saturation, and temperature can all be manipulated. Therefore, global oxygen delivery and the blood pressure can be independently controlled on cardiopulmonary bypass. This is not the case in the spontaneously circulating patient, where blood pressure is used as a surrogate marker for cardiac output and thus oxygen delivery. Again, while on cardiopulmonary bypass, oxygen delivery is decoupled from blood pressure under the conditions of hemodilute continuous flow. Adequate delivery of oxygen should be reasonably easy to ensure, as it is primarily a function of the pump flow and the oxygen carrying capacity of the blood being circulated. Just like in any other patient, the mixed venous O2 will almost certainly tell you something about the adequacy of global oxygen delivery, but will certainly miss some small, inadequately perfused vascular beds which contribute only a little to the total venous return. While a low mixed venous O2 must certainly be dealt with, a normal or high mixed venous O2 is not necessarily a reason to let your guard down. Of evolving metabolic acidemia could be a sign that something is not being adequately perfused. Without organ-specific perfusion data, it will be impossible to know specifically what is being underperfused. Outcome data on cerebral oximetry is hardly conclusive, but to the extent that it tells us something about oxygen delivery to the brain, normal cerebral oximetry might be reassuring. On the other hand, in almost all other physiologic states, the body preserves brain perfusion almost at all costs. So under cardiopulmonary bypass, will the brain be a leading or lagging indicator of the adequacy of global oxygen delivery? This is an unresolved question. A raw or processed EEG, which begins to show an inappropriate slowing or burst suppression, which is not commensurate with the effects of medication or temperature, could be a sign that the brain is not being adequately supplied with oxygenated blood. Urine output is a very insensitive marker for the adequacy of kidney perfusion. When hypothermia is used, there can be a cold-induced diuresis which occurs. Many centers do routinely add mannitol to their pump primes, and the resulting osmotic diuresis might help you with the issue of fluid balance, but will neither protect the kidneys or stave off renal failure in and of itself. This is also true of any loop diuretics, such as furosemide, which may increase the urine output, but will not confer any degree of renal protection to the patient. Following lactate while on cardiopulmonary bypass may be a trendy, if not fully validated, indicator of poorly defined badness. Even during non-cardiac surgery, the routine use of lactate levels intraoperatively is controversial. Let's sum it up by saying that there is no definitive marker for adequacy of perfusion while on cardiopulmonary bypass. Rather, a combination of reassuring indicators combined with the judgment of an experienced group of people in the operating room are the patient's best protection. Historically, an acceptable MAP has been in the range of 50 to 60 millimeters mercury. But even this is based on the alleged lower limit of cerebral autoregulation in normothermic pulsatile flow. Ideal blood pressure remains a controversial topic. To compensate for the fact that cold blood is more viscous than warm blood during hypothermic cardiopulmonary bypass, hemodilution is employed to ensure that the blood does not become excessively thick to preclude its passing through the small blood vessels without an extraordinary amount of pressure. This improved microcirculatory flow may increase oxygen delivery despite a lowered oxygen carrying capacity. And at any given flow rate, dilute blood will generate less blood pressure than thick blood. My general practice is to maintain a MAP between 50 and 60 unless there is a specific reason to drive it up to compensate for known or suspected arterial stenoses to vital organs, such as carotid or renal artery stenosis. It is entirely conceivable that some subset of patients do benefit from higher average MAP while on cardiopulmonary bypass, but this remains a question without a definitive answer. There can be confusion around pH management on cardiopulmonary bypass because there are multiple moving parts to the chemistry. The question of pH stat versus alpha stat has confounded anesthesiology trainees for years. Indeed, CO2 does become more soluble in blood as the temperature falls. Once in the blood, some of the CO2 gets converted to carbonic acid. Some of that acid will dissociate into hydrogen ions and bicarbonate. At 37 C, this would indeed increase hydrogen concentrations and thus lower the pH. However, as the blood gets colder, carbonic acid itself dissociates less, creating a lower concentration of dissociated hydrogen than would occur at 37 C. It is a fact that pure water becomes more basic as it cools and more acidic as it warms due to decreased and increased, respectively, dissociation of water into hydrogen ions and hydroxide. In a pH stat regimen, the pH of the blood will be maintained at 7.4, regardless of the patient's actual temperature. In practice, this will require the addition of carbon dioxide to the system to compensate for the increased solubility of CO2 in the cold blood. The increased CO2 in the blood will have the effect of dilating the cerebral vasculature, and this can be quite useful to rapidly and uniformly cool the brain, but it may lead to a higher embolic load to the brain. The benefit of a more rapid and even brain cooling tends to be pronounced in babies and children. The risk of an increased embolic load, however, makes a pH stat approach less useful in adults. The other approach is called alpha stat. Regardless of the patient's actual temperature, the pH of the blood will be measured at 37 C, and management of the acid-base status will occur on that basis. Alpha stat theory says that regardless of the effect of temperature on pH, the body's compensatory mechanisms, specifically the imidazole side group of histidine, ensures that the cellular chemistry continues to work. It is called alpha stat because of an esoteric term called alpha, which refers to the ratio of unprotonated histidine imidazole groups to free hydrogen ions. This imidazole group can donate or accept protons to the surrounding aqueous milieu to buffer changes to pH which occur as a result of changes in temperature. Physiologically, this ensures that cellular chemistry continues to function when there are differences in the temperature of cells in the body, as might occur in the extremities of a person on a cold day. At my institution, the anesthesiologists are generally responsible for transitioning the patient from cardiopulmonary bypass back to spontaneous circulation. This practice may not be universally true. My opinion is that since the anesthesiologist is responsible for the hemodynamics and physiology post-pump, it is entirely appropriate that the patient be separated from bypass on the anesthesiologist's terms. But practice patterns do vary from institution to institution. Recall that cardiac output is the product of heart rate and stroke volume. Stroke volume is primarily a function of contractility and left ventricular and diastolic volume. I conceptualize the transition like starting to move forward in a manual transmission car while pointed uphill. We can see in the video that the driver's left foot gradually releases the clutch only after the right foot has started to increase the engine RPMs by applying throttle. As the clutch engages and transfers load to the engine RPM drops and the car begins to move forward. Analogously, RPM can be conceptualized as some combination of heart rate and contractility. Ideally, the patient would be in a normal sinus rhythm or even in a slight sinus tachycardia when separating from cardiopulmonary bypass. In the absence of that, a pace rhythm at least guarantees an adequate heart rate. TEE, or visual inspection of the heart, will inform the degree of contractility present. When attempting to separate from bypass, pharmacologic support in the form of inotropes may be necessary. Gradual release of the clutch is the gradual filling of the heart by progressive occlusion of the venous drainage line. Assuming that the increased preload on the right and left ventricles does not precipitate heart failure, one can continue to progressively occlude the venous drainage line until blood is no longer being diverted from the right side of the heart. At that point, the patient has separated from cardiopulmonary bypass, and our car is accelerating up the hill. Apologies for the complicated representations on this slide for what is conceptually the rather simple process of weaning the patient from cardiopulmonary bypass. At the start of the wean, the perfusionist will gradually occlude the venous drainage line from the patient while simultaneously reducing the rate at which blood is pumped back into the systemic circulation. This has the effect of allowing some of the venous return to fill the right ventricle, get ejected by the right ventricle, make its way to the left ventricle, and then get ejected by the left ventricle into systemic circulation. This can be done in a stepwise fashion, allowing the anesthesiologist to make adjustments to the pharmacologic regimen and to assess the function of the heart. Failure of the left or right ventricle during the wean would be an indication to return to full cardiopulmonary bypass while the patient is optimized for another weaning attempt. The period of time around weaning from cardiopulmonary bypass is fraught with potential problems. In addition to getting the heart to function properly after reperfusion, a task which may involve the use of inotropic or mechanical support, we must also deal with some relatively common sequelae of cardiopulmonary bypass. A certain degree of pulmonary endothelial dysfunction can be anticipated in addition to the atelectasis expected after having the lungs deflated during the bypass run. Many patients do experience a predictable and transient defect in gas exchange across the alveolar membranes. Reversal of heparin anticoagulation by administration of protamine can result in the dreaded protamine reaction, a sort of catch-all phrase used by surgeons, anesthesiologists, and perfusionists to describe varying degrees of systemic hypotension, anaphylactic or anaphylactoid reaction, pulmonary hypertension, bronchoconstriction, or pulmonary edema of a non-cardiac origin. Mitigation strategies include inotrope and pressor support and slow administration of protamine over several minutes following a successful test dose. In a worst-case scenario, reheprinization and return to cardiopulmonary bypass may be necessary to preserve the patient's life. Coagulopathies of all sorts can develop after cardiopulmonary bypass. Full lab coagulation studies and point-of-care thromboelastography may be useful in guiding the administration of blood products and procoagulant agents such as DDAVP, recombinant factor VII, and prothrombin complex concentrates. In general, the greater the duration of the pump run, the more likely the patient is to develop some type of coagulopathy. Any pre-existing coagulopathic derangements, medication-induced or otherwise, may certainly exacerbate this problem. Some final thoughts on how to successfully navigate a pump run. Get to know your perfusionist by name. Establishing rapport will go a long way to smooth operation and cooperation between perfusion and anesthesiology. It's worth checking in with your perfusionist periodically during the pump run to ensure that things are going smoothly from their perspective. They can clue you into evolving problems, which gives you an opportunity to intervene before they compromise the patient's safety. Don't ever forget that it is the physicians who direct the physiologic goals for the pump run. Putting the patient on pump does not allow the anesthesiologist to abdicate their responsibility for the patient's physiology. The pump run is not the goal. It is merely a technique used to allow the surgeon to execute the surgical therapy for which the patient is on the operating table. In many cases, the real work for the anesthesiologist only begins once the pump run is complete and you are left to deal with the very real consequences of this essential component of modern cardiac surgery. Thanks for your attention. We'll see you for the next one.